The subcommittee will come to order, and I hit the gavel. It's too pretty to actually use, Mr. Chairman. The chairman was kind enough to provide us, all the new chairmen of the subcommittees, a fancy gavel, which we appreciate. I do want to take one little point of personal privilege here. We actually have our senior staffer, Sean. Where are you, Sean? Your spouse is going to have a baby in just a few hours. We are going to, yeah, we hope so. Yeah, and we won't explain how that happened. We're going to pass this little bib down, and I'm going to beg of all the members to write a little note, but they're going to induce labor in a couple hours. And I thought this would be a really neat gift from all of us, both Republican and Democrat, as a little baby bib for the new little tykes' future. Sean, stand up, wave. Hello. Yay. All right, now back to work. Without knocking over my coffee, I'd like to welcome everyone to today's Oversight Subcommittee hearing. This is our first Oversight Committee hearing of this Congress, and I'm happy that our first hearing we will be able to work with who has become my friend, Mr. Pasquale, and his team in putting this hearing together. Our approach today is not intended to be partisan or to beat up on anyone. We just want information and to understand. As I spoke with some of the witnesses, we see things coming at us from both directions. Help us understand what's actually happening in that tax-exempt world. Today's focus is tax-exempt hospitals and the community benefit standards. Hospitals must maintain certain requirements to obtain and maintain their tax-exempt status, including organizational, operational requirements, community benefits, and also those things spelled out in the ACA. When it comes to community benefits, various academics, think tanks, have sought to put a value on both the tax exemption of hospitals, which they receive, and then the community benefits they provide. We know that the tax exemptions are very valuable. One of our witnesses today from the newly named KFF, we all know as Kaiser, will talk about their work showing that tax exemptions were valued around $28 billion. And we are going to ask you how you calculated that math in 2020. With half of that coming from the federal tax exemption, KFF has also found that the value of charitable care provided by hospitals varies substantially across facilities, ranging from 0.1% in operating expenses of hospitals to some well over 7%, and some with other variances. Additionally, the Lowen, pronounced properly? The Lowen Institute have made efforts to calculate fair share spending for nonprofit hospitals by comparing each system's spending on financial assistance, community investment, to establish a value of its tax exemption. The Institute's results show significant deficits in community benefits provided as compared with the value of some of these hospitals' tax exemption. Moreover, some articles and studies, included one by one of our witnesses today, argue that for-profit hospitals, on average, provide more charity care than tax-exempt hospitals. Conversely, groups like our friends at the American Hospital Association have published analysis arguing that the value of community benefits provided by hospitals substantially exceed the value of the tax exemption. The wide variance here seems to come from the lack of guidelines and also what we've done in Congress. And the IRS now, in its definitions of community benefits. We are also pleased to have witnesses here today from the GAO, who will talk about the GAO's study, the report they did in 2020, and the nature of the standards that the IRS's inability to conduct effective oversight on the tax exemption value of hospitals. All of this makes exploring the tax-exempt hospitals and the level of community benefits they provide a worthwhile conversation. And with that, I thank all of our witnesses for being here, and I'd like to turn over for his opening statement my friend, Ranking Member, Mr. Pasquale.
Thank you, Mr. Chairman. I'm eager to kick off our first Oversight Subcommittee. This hearing and congratulations on your gavel. Our committee holds a sacred duty to ensure hospitals respond with the highest quality of care. We know one size does not fit all to provide the care our communities need. Tax-exempt hospitals deliver unmatched benefits and are the very cornerstone of our hospital system. Nonprofit network cares for our most vulnerable. You got to remember that. These hospitals collectively deliver more in benefits and charity care than other hospitals. There are nearly 3,000 not-for-profit hospitals across America. In my state, New Jersey, 65 of these institutions keep our communities healthy. I'm committed to robust oversight of our tax-exempt hospitals. Many nonprofit hospital systems can and must do better. But we cannot lose sight of the harm Wall Street has done already to our entire health system. This subcommittee must continue taking a closer look at the opaque ownership of hospitals. Private equity control is often shielded like a Russian nesting doll, designed to block oversight by the government and from patients. By tightening their grip over health care, corporate tycoons place profits over patients, big bucks over the Hippocratic oath. Our committee has the receipts. As chairman, I led a hearing last Congress on the impacts of private equity on health care. What we exposed still needs fixing. Wall Street loads debt onto companies, sometimes leading to bankruptcy, facility closures, fired workers, neglected patients, and damaged communities. In 2022, private equity investment in healthcare grew to $90 billion. PE stretches like an octopus with tentacles in large and small hospitals, physician practices, dental practices, nursing homes. These trends demand further investigation. Our committee cannot ignore how threats to hospitals harm our communities and access to care. And I thank you, Mr. Chairman, and I wish you the best of luck.
You're very kind. Thank you, Mr. Pasquale. And to the big chairman, Mr. Smith, share with us.
Thank you, Chairman Schweikert and Ranking Member Pasquale. It's a pleasure to be before your first Oversight Subcommittee. Today, the Oversight Subcommittee is meeting to examine the tax-exempt status of nonprofit hospitals to ensure they are operating in the best interest of patients, communities, and taxpayers. As the committee with oversight jurisdiction over the IRS, the tax code, the administration, and healthcare, we know this is an issue that is of great importance to Americans' health. That's not only because of the obvious essential role that hospitals play in our healthcare system, but also because of their particular importance to many communities across the country, where they are often the only option for medical treatment. That's particularly true in rural areas that many of us here represent. Nonprofit hospitals account for almost 60% of hospitals in the United States. The federal tax-exempt status granted to most of these hospitals is significant. It is estimated to be worth $14 billion, with nearly another $14 billion coming from state and local exemptions. Recent studies and articles have raised concerns, however, that the level of community benefit, which includes charity care, provided by tax-exempt hospitals has been inadequate compared to the value of their tax exemption. Additionally, numerous news reports highlight aggressive billing practices, executive compensation in the millions of dollars, and abuses in the 340B program. The level of executive compensation is particularly alarming. The top 10 nonprofit hospital CEOs average more than $7 million annually, some as high as $14 million. And this further questions whether these facilities are living up to their mission statements. In the best case scenario, tax-exempt hospitals provide meaningful community benefits that exceed the value of their tax exemptions, and some do. But given the concerns that exist, an examination is needed to determine if sufficient community benefits, including charity care, are being provided and to ensure vulnerable patients and communities are being protected. This hearing is an opportunity for us to learn from expert witnesses and identify any issues that may need to be addressed through legislation so that we can be confident that nonprofit hospitals are meeting their responsibilities and have the resources they need. Additionally, we must be sure that the laws, rules, and regulations under which they operate are clear and effective. I'm confident that together we will identify the problems and the potential improvements that will benefit patients and communities with the flexibility that they need. Yield back, Mr. Chairman.
Thank you, Mr. Chairman. Now for our witnesses. Our first witness is Jessica Lucas Judy, Director of Strategic Issues at the U.S. Government Accountability Office, we all kindly refer to as GAO. Second, G. Bai, Professor of Accounting at the Johns Hopkins Carey Business School and Professor of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Third, Zachary Levinson, Director of a new project at the KFF, we all know as Kaiser, that examines business practices of hospitals and their providers and their impact on costs and the affordability. And fourth, Belinda Hatton, General Counsel and Secretary for the American Hospital Association. Ms. Jessica Judy, your written statement will be made part of the record. You have 5 minutes. Please share with us.
Chairman Schweikert, Ranking Member Pascarell, members of the subcommittee, I'm pleased to discuss GAO's 2020 report on requirements that hospitals must meet for tax-exempt status and challenges that IRS faces with those requirements. To maintain federal tax-exempt status, a hospital must operate for a charitable purpose to promote health for the benefit of the community. In 1956, IRS required tax-exempt hospitals to provide charity care, operating to benefit those not able to pay. In 1969, IRS removed the charity care requirement. In its ruling, IRS identified 6 factors that distinguish how one hypothetical hospital satisfies requirements and the second does not. These factors, referred to as the Community Benefit Standard, include providing emergency treatment to all and using surplus funds to advance medical research. A hospital need not meet all of the factors to qualify. IRS does not have authority to define specific types of hospital activities. The factors that IRS identified are examples, not requirements. Some of the factors may have lost relevance. For example, some are now common features of all hospitals. Hospitals are required by law to provide emergency treatment to all, regardless of ability to pay. These factors may be a less useful gauge than they once were. Representatives of tax-exempt hospitals told us the Community Benefit Standard offers needed flexibility, but the lack of clarity creates challenges. A hospital could maintain a tax exemption by operating an emergency room that's open to all while spending little to no money on community benefit activities. We found 30 hospitals that reported no spending on community benefits in 2016, and other hospitals that could have been at risk for noncompliance. IRS officials told us the agency had not revoked a hospital's tax-exempt status for failing to provide sufficient community benefits in the previous 10 years. We recommended that Congress consider specifying services and activities it believes would provide sufficient community benefits. To date, Congress has not enacted such legislation. IRS requires a tax-exempt hospital to file Schedule H with its Form 990 annually. However, Schedule H solicits information inconsistently. For example, IRS directs hospitals to specify the costs for providing health education, but hospitals may describe the use of surplus funds to improve facilities and patient care in a narrative without specifying an amount. Our analysis found inconsistencies in what hospitals reported in those narratives. Some provided numerous examples, others did not address any of the factors. We recommended IRS update its forms and instructions to ensure that the community benefit information is clear and can be easily identified. IRS agreed. In response, it adjusted the instructions to indicate responses should include all the community benefit factors. However, IRS still asks hospitals to describe that information narratively. IRS could fully implement our recommendation through further updates to its forms to help ensure community benefit information is clear and can be easily identified. Turning now to the Patient Protection and Affordable Care Act, or PPACA, it established 4 additional requirements for hospitals. These include conducting a community health needs assessment and setting limits on charges and collection. IRS requires hospitals to self-report compliance with all 4 of the requirements on Schedule H, answering a series of yes or no questions for each. IRS referred almost 1,000 hospitals to its audit division for potential violations in 5 years, but could not identify whether any of these referrals related to community benefits. IRS said it sends back incomplete forms, but we found some hospitals left the community benefit section blank. IRS's guidance for its revenue agents contains specific questions that address the community benefit factors, but there was no direction on when a hospital should be referred to audit. Further, IRS could not determine if hospitals were being selected for audit for potential noncompliance related to community benefits. We recommended IRS establish a process to identify hospitals at risk for noncompliance, as well as specific audit codes. IRS updated its guidance for employees and established an audit code for the community benefit standard, which we think will help ensure it's effectively reviewing hospitals' community benefit activities. In conclusion, IRS can easily verify whether the legal requirements of PPACA are met, but it's harder to verify the community benefits because IRS does not have authority to define specific services and activities that hospitals must undertake to qualify for a tax exemption. Additional clarity about specific services and activities Congress believes would provide sufficient community benefits could help. Chairman Schweikert, Ranking Member Pascarell, members of the subcommittee, this concludes my remarks, and I'm happy to answer any questions you have.
Thank you, Ms. Lucas-Judy. Dr. Bai.
Chairman Schweikert, Ranking Member Pascarell, and members of the committee. It's my great pleasure to be here today. Thank you very much for having me. I'm a professor of accounting at Johns Hopkins Carey Business School and a professor of health policy and management at Johns Hopkins Bloomberg School of Public Health. As an accountant, my research interest is monetary issues in healthcare. Today's testimony, I will focus on 2 things. Number 1, the social contract between taxpayers and the tax-exempt hospitals. Number 2, evidence on whether tax-exempt hospitals fulfilled their obligations to taxpayers. My views today represent my own and do not represent that of Johns Hopkins University or its affiliations. Let's move on number 1. So hospitals is the largest industry in the United States with $1.4 trillion annual revenue. Most of the hospitals, however, are tax-exempt hospitals, meaning that they are exempted from income tax at the federal, state level, property tax, sales tax. They also have lower cost of borrowing because they can issue tax-exempt bonds because bond holders do not pay income tax on the interest earned on the bonds. They can also receive tax-exempt, tax-deductible charitable contributions. So beyond that, these hospitals can also benefit from the 340B program. So these 340B programs was established by Congress in 1992 to help hospitals that benefit low-income patients by giving them the ability to buy drugs at discounted price from pharmaceutical companies. This was a buy low, sell low program at that time. Now it has evolved into a buy low, sell high program because hospitals can sell those discounted drugs to well-insured patients. And it also encourages hospitals' mergers and acquisitions because they can buy physician practices and small hospitals in order to take advantage of the 340B program. More importantly, the tax exemptions or taxpayer subsidies worth more to hospitals with higher profitability and hospitals located in wealthy areas because of the value of property tax exemption and the value of income tax exemption. So these are the indirect and direct tax benefits or taxpayer subsidies enjoyed by nonprofit hospitals. How about obligations? So our current tax-exempt benefit comes from the 1913, the first Internal Revenue Code. At that time, nonprofit hospitals were pure charities. They focused on charitable activities with very little commercial activities. But time has changed. Our current community benefit standards was adopted by IRS in 1969 because we have a social contract. As tax-exempt hospitals, we are going to provide all kinds of community benefits to the taxpayers. In return, we receive taxpayer subsidies. Then the ACA defined very specifically 8 different types of community benefits, including charity care, that is the discounted or free care provided by tax-exempt hospitals to low-income patients, either uninsured or insured. And also the Medicaid shortfall, which is the Medicaid payment versus the cost of providing care to Medicaid patients. And there are other types of community benefit. So basically, nonprofit hospitals must report to IRS how much they did for one of the 8 or more than of the 8 different categories, and at an annual basis. Now let's move on to my number 2 point. The hospitals have not yet provided more than the for-profit hospitals in overall. So our study in health affairs found that in 2018, for every $100 expense incurred by nonprofit hospitals, they only provided $2.30 for charity care. But the for-profit hospital provided $3.80. And a similar result we found for the Medicaid shortfall. So overall, nonprofit hospitals have not yet demonstrated that their activities are consistent with the charitable mission. So evidence suggests that tax-exempt status does not provide assurance that nonprofit hospitals will provide sufficient community benefits or behave in a way consistent with their charitable mission. Thank you very much.
Thank you. Thank you, Dr. Bai. Dr. Levinson.
Thank you, Chairman Schweikert, Ranking Member Pascrell, and distinguished members of the subcommittee. I appreciate the opportunity to be here with you this afternoon to discuss tax-exempt hospitals and the community benefit standard. This issue has been the subject of renewed interest in light of reports on the business practices of some nonprofit hospitals, such as instances where hospitals have taken aggressive steps to collect unpaid medical bills, including from patients who may be eligible for financial assistance. To provide context for ongoing discussion on this topic, KFF estimated the value of exemption from federal, state, and local taxes for nonprofit hospitals. We estimated that the total value was about $28 billion in 2020. This represents over 40% of net income earned by nonprofit hospitals in that year, highlighting the large role the tax exemption may play in the financial health of these facilities. About half of our estimate reflects the benefit of federal tax-exempt status. The federal component includes the value of not having to pay federal corporate income taxes. It also reflects estimated increases in charitable contributions and decreases in bond interest rate payments that might arise due to receiving tax-exempt status. In exchange for receiving federal tax exemption, nonprofit hospitals are expected to provide community benefits. One core example of a community benefit is charity care, which reflects free or discounted services for eligible patients who are unable to afford their care. Hospital charity care programs help fill in gaps in coverage for uninsured patients, as well as insured patients whose plans may have large cost-sharing requirements. We estimated the nonprofit hospitals spent about $16 billion on charity care in 2020, which is less than our $28 billion estimate of the value of tax exemption. We focused on charity care to provide context for one of the clearest examples of a public good provided by nonprofit hospitals. However, nonprofit hospitals engage in many other activities that may benefit their communities. These include covering unreimbursed costs related to treating Medicaid patients, offering unprofitable services that are important for local access, supporting medical training, and funding research, among other activities. Nonetheless, research suggests that community benefit spending may vary substantially across hospitals, and some have suggested the need for additional measures to be sure that all nonprofit hospitals are carrying their weight. Several proposals have been floated to increase the provision of community benefits and better align these activities with local need. Approaches include expanding requirements for hospital charity care programs, requiring hospitals to spend a minimum amount on community benefits, requiring greater community involvement in hospital decision-making, and increasing transparency and oversight of community benefits. Policies that seek to strengthen the regulation of federal nonprofit status would inevitably involve trade-offs. For example, some policies may require new spending on certain community benefits. While hospitals may try to offset this new spending by operating more efficiently, it's also possible that some would cut costs in ways that could be harmful to patients or the broader community, such as by discontinuing certain services or laying off staff. It may be especially challenging for some to implement new activities given recent financial challenges facing hospitals and other financial challenges that are on the horizon. This includes the end of the public health emergency and the unwinding of Medicaid continuous enrollment, which could lead to many individuals losing coverage and subsequently requiring charity care. At the same time, policies to strengthen standards for community benefit could increase the provision of benefits that are important to patients and communities, such as extending free or discounted services to more patients who would otherwise have difficulty affording their care. In the context of recent financial challenges facing hospitals, strengthening community benefit requirements could also protect prioritized services and activities from hospitals' attempts to cut costs. Given the large role that nonprofit hospitals play in the nation's healthcare system, the community benefits that they provide may have a large bearing on patients' access to affordable care and the health of communities. Thank you, and I look forward to answering your questions.
Thank you, Doctor. Ms. Hatton. Could you hit your button?
Thank you. Sorry. Chairman Schweikert, Ranking Member Pascarell, and distinguished members of the subcommittee, thank you for the opportunity to testify at this hearing. On behalf of the American Hospital Association's 5,000 member hospitals and health systems, I look forward to sharing the many ways hospitals provide benefits to their communities as we strive to ensure all individuals reach their highest potential for health. Every hospital...
Ms. Hatton, forgive me, I know you're going to... Will you pull the mic closer to you?
Sure.
It's the acoustics in this room are really bad.
Thank you. Every hospital provides valuable and vital services to their patients and communities. These include 24/7 emergency care, specialized surgeries, and treatment for complex diseases that only hospitals can provide. Tax-exempt hospitals have special obligations to their communities in exchange for that privilege. Tax-exempt hospitals report the amounts they spend on community benefits yearly and conduct a community health needs assessment at least every 3 years. Hospitals work with their communities to develop these assessments to decide which priority health issues they should tackle. There's no doubt that these hospitals both meet and exceed any requirements and expectations that attach to the privilege of tax exemption. A few key facts. In 2019, which is the most recent tax year that comprehensive information is available, tax-exempt hospitals devoted nearly 14% of their total expenses to community benefit programs, and about half of that was for financial assistance and other means-tested benefits. In addition, the most recent report by the international accounting firm of EY demonstrated that the return to taxpayers for hospitals' federal tax exemption is 9-to-1. That means for every $1 of tax exemption, taxpayers receive $9 of community benefit. I think that's a remarkable return by any standard. For nearly 100 years, it's been widely recognized that fulfilling a hospital's charitable mission is multifaceted and does not rest on the provision of financial assistance alone. The community benefit standard established by the IRS permits hospitals to satisfy their community benefit obligations by providing a mix of financial assistance services and programs tailored to meet the needs of their communities. In 2008, as part of a major overhaul of Form 990, the IRS developed Schedule H. This is the form tax-exempt hospitals use to report the range of community benefits they provide. The AHA has been collecting comprehensive information on the benefits reported in Schedule H since 2009. The amount of community benefit has remained steady between 11 and 14% of total hospital expenses, with financial assistance and Medicaid underpayments counting for about half that total. Since reporting began, hospitals have provided between $894 billion and $1.3 trillion worth of community benefits. One of the greatest accomplishments of the community benefit standards is the flexibility it gives to hospitals to meet the needs of the unique communities they serve. Let me give you two brief examples. Honor Health in Scottsdale, Arizona supports its communities through a variety of programs that increase access to health care, provide early childhood education, food bank access, senior daycare, and trauma and deployment training for military professionals. St. Joseph's Health in Paterson, New Jersey works with community partners including faith-based, civic, and social organizations, schools, and others to offer a wide range of services. Some examples include educational programs on autism, diabetes, obesity, asthma, and other support services for parents of infants and toddlers with a special focus on children with developmental disabilities and delays. Every single hospital has examples of programs that are designed to address the unique needs of their communities. Before closing, just let me note that we do have some areas agreement with the other three witnesses that you've heard from. There should be more emphasis on the value of social determinants of health. The Schedule H form could and should be more user-friendly for communities. The value of grants that support programs, services, research, and training should be counted, and setting minimum dollar thresholds would not be helpful or prudent. In conclusions, hospitals do more than any other sector of healthcare to support the communities they serve, and more than enough to support their tax exemption. Thank you again for the opportunity to testify, and I look forward to your questions.
Thank you, Ms. Hatton. Now we're going to have some questions, and the benefits of being chairman, I get to go first. Ms. Lucas-Judy, a very simplistic question. If the IRS documentation were updated, Ms. Hatton just said the last time the form was updated was 2008. What would we change to make it so we would have a commonality of understanding of the community benefit being offered with this exemption?
Well, as you probably know, IRS recently came out with its strategic operating plan for using the funds from the Inflation Reduction Act. And part of the vision that was laid out there was, one of the initiatives was to revise forms in general to try to make them more user-friendly, more transparent,
You
make
beat
them
me to my
easier.
punchline. So what would you do to change the design of the form? What are the couple things we need to know?
So some of the things we need to know would be what is it that hospitals are doing to address the community benefit? I mean, right now, it's scattered on several different parts of the form, and some of the information is collected through a quantitative or a sort of contained kind of answer. Some of it, as we mentioned, 3 of the factors are addressed generally in a narrative that's then not captured in the electronic version. So it's difficult from what we heard from hospital associations. It's difficult for them sometimes to even know what to include where on the form, what kind of information would be useful. And then it's difficult for users, for members of the public, for Congress, for researchers, to be able to know where to look on the form to find the answers as to what is it that a hospital is providing.
So an update in the design of the form.
Right.
Ms. Hatton, do you agree that at least we could ever throw together a working group to just update the way we accept that information?
So, Mr. Chairman, a working group would be good, and that's actually originally how the Schedule H form was designed, by a working group. I think one of the things this committee could consider, the IRS is not one of the agencies that's subject to notice and comment. So when they update a form, when they update instructions, they don't go out to the public and those most affected.
And
To get-
to your
to get-
point, you're actually making one of the reasons for this discussion.
To widespread, to determine from the communities the ways in which the form could be made easier so that it would be easier for community members to use them. I mean, I think it's important that we don't ever define community out of community benefit, because those are the individuals that really best understand the impact of the programs and the services that the hospitals are providing, and the ability for them to use the form and understand the form more
Understood.
easily is
Yeah,
paramount.
but much of my concern there is actually much more mechanical. When we all look at the form, to be able to make policy decisions off the data. Ms. Bai, you said a couple things that I need to understand as an accountant or as an expert in public accounting. How did you get to the conclusion of here's your value of the tax exemption, and here's what you see being put out in charitable care, community benefit? Could you first walk us through the numbers as your research demonstrated, and how did you partially get to that math?
Sure. I love that equation analogy. Yes, on one side, let's first look at taxpayer subsidies, right? Right now, let's assume let's put aside whether the 8 categories of charity care or community benefit is justifiable or not. Let's assume they are. Then IRS Form 990 Schedule H already has very explicitly, right, charity care, Medicaid shortfall, everything listed by the line. But what is missing is how much taxpayer subsidies received by these hospitals at the hospital level. Let's say we add 3 lines on the Schedule H. Number 1, foregone property tax. Number 2, foregone sales tax. Number 3, 340B profit or gross profit. So that will help tremendously for the public and the stakeholders at every level to compare. Right? On one hand, you have the taxpayer subsidies. On the other hand, what is the tax benefit, right? And how much you give back to community. And also, by the way, this is a very conservative measure. Why? Because a lot of the community benefit categories, charity care, Medicaid shortfall, and education, community, all these things are also provided by for-profit hospitals as well. So this is a very conservative measure.
Well, first, back to one of the cores of the question. Here's the value, as you were looking at nonprofits, here's the value of those levels of tax benefit. Over here's what you saw going out in charity care, community benefits. And I will tell you, I had a hook at the end. I wanted to see across the country how many received disproportionate share benefits also as a backfill. What is that differential in your research? What's the gap?
So that is the reason we're here, right, to discuss this cohort, because there's no way to know at the hospital level how much is the taxpayer subsidy. Now, our friends have already estimated, but that is at the national level, and that's based on a lot of assumptions. At the individual hospital, how much is the income tax that they would have paid if they had been for-profit? There's no way to know, because the taxable income is very different from disclosed accounting income. And also property tax, right? We do not know. And think about the hospitals in a very wealthy area. Their property tax is going to be very high, right, compared to a hospital in a rural area. So that's why we need disclosure. We need IRS to have the disclosure on the Schedule H.
Well, Dr. Bai, but in some of your testimony, you actually have some estimates of what that gap is.
So, that I think is from Kaiser Family Fund. They have about $28 billion.
Well, that's Kaiser's
Yeah.
estimate of the value of the tax exemption.
Mm-hmm.
And do we have actually, in any of your research, have you ever attempted to do the value of the, let's just call it charity care?
Charity care is lower than that, yes. Okay. So we have the same conclusion. So the tax exemption value as estimated is actually lower than, it's higher than the charity care provided.
Okay, Dr. Bai, my last question is, how did you come up with the calculation that you believe many for-profit hospitals are actually taking and providing more as a percentage of their book of value in charitable care?
Thank you so much. The for-profit hospitals are minority, right, in the hospital industry. So we found in 2018, for every $100 expense incurred by hospitals, the for-profit provide, this is in aggregate, a $3.80. Okay, that's in aggregate. But for nonprofit, it's about $2.30. So that means the nonprofit in aggregate provide less charity care than for-profit counterpart, which actually pay tax. And I have no reason to believe that things have changed in 2019 or 2020. But that's the overall picture. And we found the similar results for Medicaid shortfall, which is also one of the most important community benefit components. The nonprofit do not have evidence, there's no evidence that they nonprofit hospitals provide more Medicaid shortfall than for-profit hospitals, which again, pay all the taxes.
Okay, the last thing, and then we'll go to our ranking member. When you've been doing your calculations, were you also able to see if there were certain state backfills, like in our Arizona system, or in disproportionate share that also backfills some of these, the charity care?
That we did not examine. Chairman, so right now there's no benchmark, right? We do not know if the charity care or community benefit is sufficient or not. That's why we chose to look at a benchmark using for-profit ones. Yeah.
All right.
But that's a great question.
Thank you, Doctor. And to our ranking member, Mr. Pasquale.
Chairman? Ms. Hatt, all the folks that gave testimony today know what they're talking about. I want to ask questions in a particular area. You touched on it, so you're going to get most of the questions. So please share some of the upstream projects our nation's nonprofit hospitals have undertaken to address social factors of health in the wake of COVID-19. Could you tell us some of those projects so we can put it in context what we're all talking about?
Thank you. During COVID-19, hospitals stepped up into many shoes. They worked with the public health agency. In fact, many of them became the public health agencies to both develop effective testing kits, to reach out to their communities to provide effective information and accurate information on both the virus and the vaccines. And many of them stood up vaccine sites in very innovative ways to assure their communities got vaccines. One of our favorite examples is in Charlotte, North Carolina. One of our hospital systems partnered with the Charlotte Motor Speedway to be able to give vaccinations to those in attendance at the race. So hospitals really stepped up in an enormous way to fill those kinds of gaps, all of which demonstrates commitments to their community. There are many other upstream activities that hospitals also undertake around social determinants of health, whether it's food pantries, whether it's education, whether it's training, whether it's work training, whether it's education for professionals. One of the gaps, one of the workforce gaps that I think this committee is very aware of, in particular, is the shortage of nurses. And we find that many of our hospitals are spending considerable resources to open training opportunities, to give training opportunities to nurses, because every year there are many more applicants for nursing slots than there are training opportunities.
Let me ask you this. The Ernst and Young report, very specific report, very specific about what we're talking about today. That report was from 2019, I believe. Nonprofit hospitals provided over $51 billion in unreimbursed expenses and means-tested government programs. Do you have a sense of what that amount was in 2020 to 2021 during the height of the pandemic? Does anybody?
We don't yet have that information, both because the IRS gave tax-exempt hospitals some additional time to file their Form 990s and Schedule H's, but also because the IRS is behind on processing them. So we
has
don't
everybody
expect to
filed?
have that information till closer to the end of the year.
Has everyone filed now that we're in 2023?
We don't know if everyone's filed. Again, hospitals, the IRS gave hospitals an extension on filing for this year because of the pandemic. So the number of actual Schedule H's that are available are just a fraction of what you usually see this time of year. And again, there's some processing issues on the part of the IRS. So again, we don't expect to have that data until later this year. But when we do, we'll be happy to share it with the subcommittee and do our annual Schedule H report on that data.
Can anyone add anything to Dr. Bay?
Thank you. Thank you, Ranking Member. In our study, we did not have direct number on the what you just mentioned, but we found that the overall profitability of hospitals actually increased during pandemic. Why? Because of relief money. So looking at operating income went down because no patients came and a lot of canceled, delayed procedures. But because of the relief money received, they actually enjoyed a higher financial viability, higher profitability than before the pandemic. In other words, Congress has provided them more than their fair share to endure the pandemic. That's our study found.
I can't, my time's out, but God bless you. Providers and patients, I hear this all the time, and so do you. The healthcare workforce is in crisis. Tell me how this has impacted our nation's nonprofit hospitals. Just be brief, but to the point. Speak up, please. You shut your mic off?
Nope, should be on.
Now you put it on.
Okay, sorry. The chronic shortages in workforce started before the pandemic, but they were greatly exacerbated by the pandemic and persist today. Nonprofit hospitals have been impacted a number of different ways, including by the costs, particularly of contract labor, going up twice or 3 times what they were before the pandemic. In fact, a number of the members of this subcommittee signed a letter to the Federal Trade Commission asking it to investigate alleged price gouging by staffing agencies because of those price increases. The price of materials skyrocketed and has continued to skyrocket. And just the general inflation that we see in the economy has also impacted hospitals. So all of that has made the workforce shortage a top priority for America's hospitals. And many, as I indicated earlier, many community benefit efforts on the part of nonprofit hospitals are now being directed to train individuals to try to alleviate that shortage.
Thank you very much for your testimony, all of you, and thank you, Mr. Chairman.
Thank you, Mr. Pasquale. Mr. Fitzpatrick.
Thank you, Chairman Schweikert, for holding this important hearing. In my home state of Pennsylvania, we do not have a public hospital system. In 2021, uncompensated care in Pennsylvania approached $900 million, an increase of just under 5% from 2020. First question, Ms. Hatton. How, in your estimation, how, if at all, has the amount of community benefit provided by tax-exempt hospitals changed over the years?
The amount of community benefit actually, since we've been measuring it for Schedule H, has remained quite steady between 11 and 14% of hospital expenses. And again, about half of that has been for financial assistance, Medicaid underpayments, and other means-tested programs.
Satin, your testimony mentions that the national uninsurance rate reached an all-time low of 8% in the first quarter of 2022. How do you believe that has impacted the amount of community benefits, including charity care, that the hospitals are now providing?
We don't yet know that for certain, but we expect that that will mean that there is likely more impact on Medicaid underpayments in the future, because with more individuals qualifying for Medicaid during the pandemic.
Okay. I yield back, Mr. Chairman.
Did I misunderstand your question?
No, you got it.
Okay.
Yield back.
Thank you, Mr. Fitzpatrick. Ms. Chu.
Ms. Hatton, in your testimony, you highlighted the importance of having flexibility in the community benefit standard to allow hospitals and health systems to support the social determinants of health that most impact their specific communities, including safe housing, nutritious food, and transportation. For example, in my district in California, Monterey Park Hospital uses their tax-exempt status to provide free transportation to and from the hospital for patients within a 10-mile radius for outpatient services, emergency room service, surgery, and admissions. Can you expand on the importance of sustaining this flexibility in the community benefit standard so that hospitals can tailor their services to the unique needs of their communities?
One of the geniuses behind the community benefit standard has been exactly that kind of flexibility, so that hospitals can look at their communities to determine what it is they need. Is it food insecurity? Is it transportation needs? Is it employment? Is it education? What exactly are the deficits? And I should also mention that hospitals do this in a couple of different ways, including through the community health needs assessment, where they work with the community and public health authorities to determine exactly what the highest priority needs are in that community. And they work together, again, with these same groups to develop a plan and actually evaluate the impact of the plan. So the community benefit standard and its flexibility has been essential to allowing communities of all sizes with all different needs really to be able to prioritize those health issues that they can tackle along with their communities.
And do you think Form 990 Schedule H captures the amount that hospitals are putting in, such as this?
I think it's probably an undercount, particularly on social determinants of health. One of the recommendations that we had and others have had is to elevate the importance of social determinants of health and make it more clear and I think more evident to those who are filling out the form of the importance of capturing that information and putting it on the form.
Director Lucas Judy, it's clear that there are many nonprofit hospitals that deliver community benefits to our communities, but in recent years, certain tax-exempt hospitals have pursued aggressive debt collection, denied charity care to those who qualify, and have engaged in anti-competitive practices at the expense of patients and taxpayers. In your testimony, you mentioned that hospitals' Form 990 and Schedule H can be the primary or sole source of information available to the public to understand the community benefits provided by a tax-exempt hospital. You pointed out certain deficiencies in the reporting, and I'd like to know specifically what sort of things would you change to update Form 990 Schedule H to include clearer information to the general public and to Congress. For instance, what would you do about the narrative issue? Because you outlined that the narrative doesn't get transmitted to the public at all in the electronic reporting? And then also, would you require an answer? Because you pointed out that some hospitals had extensive answers there and some had nothing at all. And would you eliminate some questions like the provision of emergency care at the emergency room?
Well, what we looked at is what is IRS doing to determine the extent to which hospitals are providing community benefits, and what is it that they're reporting as part of that oversight. And what we found is that the form really doesn't allow anyone to do that because, for one thing, the community benefit standard itself really is not a standard. It's a series of examples of things that could be provided. But even if you were looking at those factors that currently make up the community benefit standard, they're on different parts of the form. And as I mentioned, some of them are closed-ended questions, some of them are open-ended narrative and sort of more optional. That narrative question tries to address several of the factors and even go beyond. And so IRS really is left with a facts and circumstances determination in each case. And so, one of the things for a good tax system is to make sure that you're treating similar taxpayers similarly, and right now you really can't do that, either with the standard as it currently is determined and also in the reporting itself.
So what would you do about the narrative problem?
Well, that would be something that it would be up to IRS to determine how to do, but if those factors are important, then we think that IRS could design the form in such a way so that the factors are more clearly addressed.
Thank you. I yield back.
Thank you, Ms. Chu. Mr. Stubbe.
Thank you, Mr. Chairman. Nonprofit hospitals derive substantial benefits from their tax-exempt status, but in some cases aren't providing the charity care that their nonprofit status requires. Nonprofit hospitals have an obligation to serve indigent patients and not try to push them off on other hospitals, but the numbers show they aren't doing this. For instance, in 2020, nonprofit hospitals received almost 40% more in tax benefits than they provided in charity care. A New York Times report found that a nonprofit hospital in New York City received nearly $250 million in tax benefits a year, for which they are supposed to provide charity care. But according to the report, that hospital routinely told ambulance workers to take homeless patients to other hospitals. My question is for Dr. Bai and Dr. Levinston. There are several requirements that tax-exempt hospitals must meet to maintain tax exemption, two of which include maintaining a written financial assistance policy for needy patients and the requirement that hospitals set billing and collection limits. But we are increasingly hearing about how some nonprofit hospitals are making it difficult for eligible patients to get financial assistance, are delaying checking patients' eligibility for financial assistance, and are sometimes engaging in aggressive billing and debt collection practices. Are you familiar with these practices? And if so, can you elaborate on the practices you have seen from some hospitals? I'll start with Dr. Bai.
Thank you, Representative Stubbe. Thank you very much for the question. What we have seen is that hospitals have 100% discretion in designing those eligibility criteria, right? To start with, if you have your resource available, you can make the policy very generous. So many people would have been qualified to receive charity care. That's number one. But what we are seeing is many hospitals did not do that. And beyond that, as you already mentioned, they are trying to make the charity care policy very obscure. So patients under stress would not be able to find the policy, so they would lose the opportunity to apply for it. And then after that, once they incur debt, some hospitals go into very aggressive techniques to go after them, garnish wages, etc. So these, as you mentioned, this is really against their charitable mission, not consistent with what's the purported mission statement.
Dr. Levinson, you have anything to add to that?
I agree with everything Dr. Bai said. I should also mention there, again, is a requirement that hospitals have a financial assistance policy in place. As Dr. Bai was mentioning, there are fairly limited requirements of what that financial assistance policy has to entail, and that both includes who's eligible for charity care, but also it grants hospitals substantial flexibility in their application procedures and how often they have to notify patients of their eligibility. So for example, hospitals are currently required to make a reasonable effort to determine eligibility before taking extraordinary collections actions. However, that could, for example, include notifying a patient of their eligibility and giving them 4 months to apply for financial assistance. There are some areas of the country where states have required more transparency around financial assistance policies, such as sending patients information about financial assistance with every bill that they receive and once their bill goes to collections.
And I'll just stick with you, Dr. Levinson, if that's okay. When nonprofit hospitals aren't providing the charity care that they are obligated to provide, how does that impact other hospitals that are in the area? Dr. Levinson first, and then you can add if you want.
Thank you for that question. So, in theory, it most directly impacts the patients at those hospitals who ultimately might be saddled with medical debt. It could also, I think, conceivably lead to some patients choosing to receive their care at other hospitals, where those hospitals will in turn be obligated to cover their charity care costs.
Dr. Bai, you want to add something to that?
Thank you. And more importantly, these patients are not high-income patients, right? Many of them are struggling working-class Americans, very marginalized. And if they are being collected, very aggressively pursued for the medical debt, they might just give up and fall into the welfare trap. That will increase taxpayer burden. See, there is a social contract. So the taxpayers let the subsidy go to nonprofit hospitals, but in return, they must help taxpayers by helping those marginalized and very struggling low-income Americans so they can stay in the workforce and stop being a taxpayer's burden. So I think that is the breach of the social contract.
Well, and real quick, I only have a couple seconds left. And for both of you, of the various types of community benefits that hospitals provide, how many of those do hospitals receive reimbursement for through other means such as Medicare, Medicaid, DSH, 340B, et cetera? So they're taking that as well, correct? Go, Dr. Bai.
Thank you. So right now, there's no transparency regarding the 340B program. So it has become a buy low, sell high program. So that is the transparency we probably need. But in the DSH also is a black box. The tax exemption value also, as we have mentioned, you don't have the information at the hospital level. Thank you.
I'd ask unanimous consent, Mr. Chairman, to add, hospitals often don't help needy patients, even those who qualify. Ask unanimous consent to add that to the record. And also the New York Times article, they were entitled to free care, hospitals hounded them to pay.
So ordered. Thank you, Mr. Stubbe. Mr. Snyder.
Thank you, Mr. Chairman. Chairman Schweikert, Ranking Member Pascrell, thank you for having this conversation. The witnesses, thank you for sharing your perspectives and insights as we try to understand this issue better. I think back through the pandemic and even the years before that, I visited hospitals throughout my district. And I hear the same concerns repeating themselves over and over. And among the most, Ms. Hatton, you touched on it, is just getting good providers, whether it's nurses or doctors. We are struggling. And I live in the suburbs of Chicago, in a place where there's a lot of access. Rural communities, I know, are having an even harder time. And we know that the first responders, the frontline workers, the doctors, the nurses were the heroes of the pandemic, but they've been squeezed as well throughout this period. And so as we come out of the pandemic and we're looking forward to making sure people have access to care, access to quality hospitals is critical. Ms. Hatton, you touched on the fact that these nonprofit hospitals providing community benefit, it's $9 for every dollar they're benefiting. Would love to get further expansion of how that's working, how you see that $9 playing and the impact it's having. But in particular, with respect to training doctors and nurses, these are often the places, the hospitals are often the places where our professionals go for that medical training.
That's a major focus for many hospitals to provide training opportunities for workforce. And again, it's become the workforce shortages in focus before the pandemic that were exacerbated by the pandemic made those programs even more important. Again, particularly with nurses, and I know in the Chicago area that you're suffering from a shortage of nurses. And again, one of the issues there is there's so many more applicants than there are training opportunities, which means that hospitals, part of what hospitals can do on community benefit is to open up more training slots so that more applicants have an opportunity to actually train. And they're doing this one in a number of different ways and a number of different staff shortages. But it's a major focus. And I expect when we see the next iteration of community health needs assessments, we'll find training for the workforce becomes one of the priority programs that hospitals want to tackle together with their communities.
Great, thank you. Let me turn to Ms. Lucas. Judy, we were talking about the form, and I know others have asked, how do we make the form better? If I'm trying to understand this correct, if I think I understand this correctly, the form basically asks the hospital to quantify their contribution, but without full meaning, without full capture of data. Is that a fair statement?
For some of the factors, it's asking for a quantitative answer, and for others, it's just what is it important to know about the community benefit that your hospital provides. That's very amorphous.
Okay. So at best, it's a partial quantification. At worst, it's an amorphic description. It doesn't get into the quality of the community service provided. It is a partial snapshot. Is that fair?
Right, and it's a form that's attempting to get something very complicated, and that's part of why we think it's important for Congress to maybe clarify what the community benefit standard ought to be, or what some of these things that have been discussed, whether it be the social determinants of health or other things. If a hospital is providing these services and we're going to be subsidizing it through the tax code, it's important to be clear about what those types of things are and still preserve some flexibility to be able to meet local needs.
And going back to my previous question, training the next generation of doctors or training nurses and other medical professionals, that's something that has value not just to the specific community, but to the nation as a whole. Is that fair?
Certainly that is one of the things that could be considered.
And my last question along these lines, so we have partial quantitative, we have a very superficial qualitative description, not a quality assessment. But the other thing I'm hearing is we don't have the transparency necessary to fully understand what community benefits are being provided. And I'm running out of time, but is that a fair statement as well?
Yes, that's correct.
So for us, it's better numbers, more transparency.
Correct.
Be the short thing. All right, I yield back. Thank you very much.
Thank you, Mr. Schneider. Ms. Tenney.
Thank you, Mr. Chairman, and thank you, Ranking Member, and thank you to our witnesses. I have a pretty extensive background serving on different levels of hospital boards, and especially in the rural upstate communities where I'm from. My grandfather founded a hospital in a rural community in upstate New York, and it's always been a struggle to get quality care, and I think it has to be emphasized that New York City, even Westchester and Long Island, is very different from upstate New York in terms of evaluating the hospitals. And I understand the ability to take advantage of this tax-exempt status. All of the hospitals in New York are nonprofit, and 2 are actually county-owned, including one in Wyoming County, which is in my district, and another one outside my district. But I want to just jump right into some of the questions I have. I want to get into just asking, and first I want Ms. Lucas, Judy, you've done a good job of explaining how vague and amorphous this standard is on defining what community benefits are. Could you tell me on the 990, the Schedule H, what would you do to improve this, and what could the hospitals provide? And I know this is a multiple-part question. Could you tell me, in your research, have you seen a distinction between upstate, rural New York, and downstate, if it's in any of your studies, or even in any other state that has a not-profit hospital system?
To that last question, that wasn't part of the scope of this particular review. But I can tell you that in earlier work that GAO has done, we did find quite a bit of variability in terms of even the types of information that hospitals were providing, the definitions that they were using, and the ways that they were measuring their charity care and uncompensated care, and some of that had to do with different standards at the state level as well. In terms of things to do to make the form itself, I mean, ideally, as IRS is looking to make all of its forms more user-friendly, both for the taxpayer who's having to report the information, as well as people who are trying to, get information from it. This I think would be a good form for them to look at to figure out is there an easier way, a more transparent way to get this information reported? But sort of in the short term, we think it's important to be able to cover all the different factors that IRS considers to make sure that its reviewers have that information to be able to determine whether a hospital is meeting the community benefit standard.
Well, let me ask you, do you suggest that we in Congress come up with a different standard for non-for-profit hospitals, or do you think we need to do better oversight?
I think not necessarily an either-or question. I think certainly having some more definition around what the community benefits are that a hospital could be providing would certainly be helpful to make sure that taxpayers, different types of hospitals are being treated the same and have that same opportunity.
So in your September 2020 GAO report, you identified 30 hospitals that reported spending nothing on community benefits in 2016. In addition, 48 hospitals reported spending nothing on financial assistance, and 108 hospitals reported spending less than 1% of expenses on community benefit spending, placing them at a high risk of noncompliance in community benefits standard, as you've pointed out. What do these hospitals generally state in their community benefit standard to meet this? I know you sort of answered that, but what did they say? Like, what was listed? Because we do have, obviously, a concern about that, and I don't know if these are upstate hospitals or profit or not. I mean, I don't know. I don't know which state they're from, but
right. So we weren't identifying specific hospitals, but we were flagging this as an area of concern and something that seems like it should have triggered some additional review on.
I guess what I want to
IRS.
say, let me reclaim it 10%. Are these hospitals, were they more rural? Were they more suburban? What would you say? Was there some commonality that you could say that you saw in the trending on the?
That was not information that we had. We did refer them, all of them, to IRS, and some of them did go back and get additional information on. And it's not necessarily that those hospitals were not even spending money; they just weren't reporting it. And so that part of our point was that the form itself isn't being used effectively for oversight, because if you had,
So I understand about the form because we've talked about whether we should change it. But let me ask you this: there is a big difference state to state. And did you in your study come up with a difference between, say, states like New York, which have a very different type of healthcare system, and it's really burdensome for rural hospitals to survive. Most of them in my area are really in free fall. I mean, because of the mandates coming from the government in Albany. I mean, would you say there's a distinction, say, based on state to state in the way we do healthcare?
That definitely was not in the scope of this work, but I do know that again in earlier studies, trying to find a difference, looking at different kinds of states and different uncompensated care that they were providing, the differences between the nonprofit and the for-profit hospitals was actually very small.
Wow, that's interesting. Thank you so much. I think my time's out.
Thank you.
Back.
Thank you, Ms. Tenney. Ms. Dilbany.
Thank you, Mr. Chairman, and thanks to everyone for taking the time to join us today. Greatly appreciate it. Ms. Lucas-Judy, we've been talking a lot about how challenging it can be for the IRS to determine whether a hospital is providing sufficient community benefits because the requirements are so ambiguous. You also recommend that the IRS assess community benefits at the facility level rather than the collective organization. And I wondered if you could talk a little bit about why you think that's important to increase transparency and enforcement.
Right. So one of the things that we found, as you mentioned, was that the community benefits were reported at the aggregate level, at the organizational level, and not at the facility level. And when you have very, very large organizations full of multiple hospitals, all reporting one level of community benefit, it's very difficult to know, maybe one hospital in that system is contributing and not the rest of them at all. And so for a transparency and accountability perspective, that's difficult. We recommended that IRS assess the costs and benefits of changing that reporting, because for the ACA requirements, those are at the facility level rather than at the organization level. IRS looked at that qualitatively and determined that the administrative burden that it would put on the hospital and on IRS was not worth the tax administration benefit that they would get. We still think it's important for transparency, but we understand their point.
Okay, thank you very much. Also, we were talking about the importance of healthcare services to our most indigent communities, and despite the benefits, we know that there needs to be increased oversight. And there was reference to a New York Times article last year where Providence, a nonprofit hospital system that actually has a large presence in my state of Washington, engaged in aggressive practices intended to increase payments from patients who should have received free or discounted medical care. Ms. Hatton, I was wondering, how can the federal government increase oversight of tax-exempt hospitals to ensure that their practices are consistent with the law? Yeah, there you go.
There really is I think, a great deal of oversight for hospitals now, and there's a great deal of transparency when you look at all of the different parts of the requirements for tax-exempt hospitals. One, there's the reporting on Schedule H, which is really quite comprehensive, but there's also the community health needs assessment, and again, that's a report that's done by the hospitals in conjunction with the community, with the public health authorities and civic groups, including civic groups that represent disadvantaged communities, to determine, not only just to determine the priorities, but determine how the priorities will be addressed and whether or not they've successfully addressed them. That's really a lot of oversight, I think, for what tax-exempt hospitals are doing in their communities, on the community level.
Ms. Lucas, Judy, is there anything you'd add there? Because clearly we need to have oversight so we can see if folks aren't receiving the benefits that they deserve. What else can we do to make sure they are operating?
The ACA required IRS to do triennial reviews of the hospital's compliance with the other requirements, and that included things like the community health needs assessment. And we found that IRS had, in doing those reviews, had referred about 1,000 hospitals during the 5-year period that we examined for their audit and examination. They were working, treating some of the initial reviews as sort of educational opportunities to make sure that hospitals were aware of their requirements, and we saw that the self-reported compliance with all the ACA requirements did go up over the course of time that we were of our review. But the one thing that we found was that, again, IRS didn't have the mechanism in place to be able to say whether or not any of those reviews looked at community benefits. And so they made a number of changes to their guidance for doing the reviews and to the way that it codes the results. So we'll be curious to see the results of that in a few years.
Thank you. Thank you, Mr. Chairman. I yield back.
Thank you, Ms. Del-Benny. Ms. Fishbach.
Thank you, Mr. Chair, and thank you so much for all of our testifiers, all of our witnesses here today. I appreciate it. And I'm from Minnesota. Minnesota's hospitals and health systems contributed $3.3 billion to their communities and $649 million in uncompensated care in 2020. In my district, small-town hospitals are more than just a place where people receive health care. They act as a staple in the community, helping bridge the gap between workforce, education, and law enforcement. Our nation's opioid and chemical dependency crisis is out of control. I think everybody can agree with that. Facilities such as the ones in my district have partnered with community members and outside organizations in their area to come up with collaborative prevention efforts that include unused medication disposal systems and strengthening relationships and creating referral pathways between mental health and chemical dependency providers, clinics, law enforcement, emergency medical, schools, and social services. So there's a whole array of things that those hospitals are helping with and doing. One hospital, I'll just use the example, is actively participating in the program is in Alexandria, Minnesota. It's a small town of less than 15,000 people, and it was first Minnesota hospital to be named one of the top rural and community hospitals in the nation. So this is what's happening in rural areas all across our country. It's obvious that the incredible relationship that they share with their community, law enforcement, schools, and other community leaders has helped this hospital to thrive and address the needs of the community. Minnesota is my home, and it is home to many, many nonprofit, small community hospitals that utilize these tax exemptions to support the healthcare communities, to the needs of their communities. Dr. Bai, how has the healthcare landscape changed since this tax exemption was first made available to those hospitals?
So if we think about the origin of the tax exemption, 1913, at that time, hospitals got the tax exemption because they were charities, right? They have the doctors and the nurses as volunteers. But then things have changed because think of the proportion of the revenue coming from commercial activities versus coming from charity activities. So totally different today. That's why our community benefit standard has to also change to to be consistent with this. But I want to emphasize that any heavy-handed policy efforts will have a lot of unintended consequences on hospitals, as you just mentioned, right? Is there some hospitals with a lot of financial vulnerability? And if we have some bright line initiatives, and they might be under a huge pressure and might close, and that will affect the access of care to the local community. So therefore, I believe still we should do disclosure, then let the local community decide, state or local level decide what to do, because they really pay the lion's share in terms of taxpayer subsidies, because property tax is almost always the largest component. Thank you.
And maybe you can just go a little bit more into, if the requirements that the hospitals must abide by to obtain and maintain their tax-exempt status. I'm sorry, I'm fighting a cold, so sometimes I'm stuffed up. But how have those changed to reflect some of these changes in the landscape? Maybe you could go into a little more, you kind of mentioned it, but if you can go into a little more detail.
Yeah. There's very little evidence that IRS or the state attorney general have used tax exemption as taken away tax exemption using any evidence. There's no such enforcement. And recently in Pennsylvania, four nonprofit hospitals lost their property tax exemption because of special statute in Pennsylvania. So I would say so far the threat has not been credible from the enforcement at federal or state level.
Okay.
They have been enjoying the tax exemptions.
Well, thank you very much, and I appreciate it. I was going to ask about the same thing that Ms. Tenney was asking, so I appreciate that she asked that and there was that discussion included, because that's a concern too. But thank you very much, and I yield back.
Thank you, Ms. Fischbach. Ms. Moore.
Thank you so much, Mr. Chairman, Mr. Ranking Member, and our witnesses for being here today. This is a very important topic, and I really have been listening very carefully to the questions that my colleagues have been asking and your responses, and it's really given me a lot of thought about whether or not we ought to constrict the definition of what community benefits are, or whether we ought to leave the flexibility there, because communities are so very, very different. And I also, I'm going to ask a question. I have no idea what the answer is to this question, but I know it's a source of frustration for me. Ms. Haddon, you talked about social determinants of health, and one of the frustrations we have around here is that there's not a lot of dynamic scoring on healthcare issues, so that the predictability, so that they won't necessarily score as a benefit or preventive medicine. So if I, for example, as a hospital, decide, I'm in a community where there's a lot of diabetes, and so I give 6 workshops a year on, cooking and alternative eating styles and so on and so forth. Can I only claim as a community benefit the amount of money I spent on the lecturer and the venue and the food? Or can I come back and say, we've reduced diabetes by 20% based on our outreach to the community? And if you can't do that, then what, Ms. Bai, you might want to jump in. How are we accounting for community benefits if we aren't allowing the institutions to demonstrate through what they're doing that there's some impact? It could be any numbers of things. We see that, kids are poor, so we're giving out fruits and vegetables to increase the fruits and vegetable intake. And, a year later, obesity has decreased. So I guess who should I ask? Should I ask you, Ms. Hatton, Ms. Bai?
You can do both.
Okay.
You can take an exemption on your, you can take the credit for it on your Schedule H for the amount that you spend on those workshops. But that's where the second part of your question is where the community health needs assessment comes in. And that is, if this is a need of the community, and again, hospital working with community groups determine that this is a need, one of the things that among the things that they're going to document is what is the need, what's the plan to tackle it, and what's the results of tackling it. So you get really transparency in two different ways. One, you get a number, which, you know, when you come to social determinants of health, the amount that you spend on it may not really be commensurate with the impact. It may have a huge impact on people's lives.
And that's my conundrum, because Ms. Bai said, you know, I heard her say more than once that some of the, you know, publicly, the nonprofit hospitals don't necessarily provide as much community impact. But I mean, if we were to have this sort of dynamic scoring, you know, to be able to say, yeah, you know, we reduced diabetes in this community, and not just, you know, and to be able to add up and count up how much diabetes costs every year, and so on. Ms. Bai.
Thank you so much, Ms. Moore. One challenge is to measure, right, the impact of the hospital on the health well-being of the community residents. And the second, if we are, as GAO report has already mentioned, that right now the reporting is already quite complex and there's lack of standardization. Once we have to remember is when we make the standards very complex, it's become a very regressive system. The rich and the powerful hospitals will be able to hire consultants, right, to window dress, to make themselves look good.
What do you think, ma'am? Got 27 seconds.
Well, certainly, I mean, accountability is our middle name, and so we do think it's important for there to be some accountability, some transparency, some measures in place for the community needs assessment. You know, part of it was
But what about the conundrum with how they're scored? I mean, prevention, this is why people say we have a sick care system instead of a health care system. You know, because prevention, if it were scoreable, maybe people would do more of it. And providing it as a general healthcare practice, you know.
And those are definitely things that Congress could consider if it wanted to, you know, put in place, like what is it that we want from our hospitals? What is it that we think some of these community benefits could be? And what kind of reporting, what kind of outcomes is it important for them to be able to provide to demonstrate that they are making a difference in the community?
Okay, thank you. My time is up. Thank you.
Thank you, Ms. Moore. Ms. Van Dyne.
Thank you, Mr. Chairman, and thank you to all of our witnesses. This hearing is about access to quality care for all Americans and having good options for getting that care. And while nonprofit hospitals can serve a critical role in providing a benefit to our local communities, I have serious concerns about the IRS guidelines that are in place that are used to identify whether a hospital meets those requirements. We've talked about that, you know, pretty much all day, but in some cases, it looks like a patient with financial insecurity needs to fill out more paperwork to receive financial aid than it does for a hospital to obtain nonprofit status. In a Wall Street Journal article published in November of last year, they detail how a patient must use a 19-item checklist that includes 3 months' worth of bank statements that must be shown and show all deposits and withdrawals, loan information on all cars that they may own, and among other things, a list of the applicant's monthly expenditures for 17 different categories. They must do all of this while meeting a 10-day deadline set by the hospital to file their paperwork to see if they even qualify for financial aid. Meanwhile, a nonprofit hospital only needs to satisfy the limited and very vague requirements set by the IRS to maintain their status. This is clearly one example of how things can go wrong. So I'm glad that we're having this hearing today, that it shows that when Congress delegates authority to an executive agency without sufficient oversight, agencies like the IRS can create more confusion and bureaucracy in our healthcare system. Dr. Bai, is the excessive amount of paperwork required to be completed by a patient in financial distress to receive access to care Is that a requirement by the IRS?
It is actually indirect requirement from IRS. So the IRS says hospitals must have an eligibility policy there. What exactly in the policy is up to the hospital to decide.
So it's not the IRS then that's requiring it. The hospital gets to decide.
The details, exactly. But
So,
you have
so
to
the
have
IRS
that.
is not requiring that they fill out a list of every single expenditure for 17 different categories.
Yes, that's correct. So if a hospital want to do good things, they can. They can make it very accessible and tell the patients face to face and make it like one-step process. Or if they want to do, like try to increase their revenue and reduce their charity care, they can make the process very, very complicated.
Okay, so this sounds like it might possibly be a hospital that's trying to avoid financial aid through creating a very overburdensome paperwork trail for their patients.
Mhm. And also increase eligibility, the floor level. Let's say 300% federal poverty line.
Is there something that Congress can do to address this?
So I think if we have a broad, bright line requirement of eligibility, then there will be variation, right? Some hospitals, wealthy neighborhood, they want them to be more general, right? But some hospitals in a poor neighborhood, you want them to be, especially facing financial threats, you want them to be more flexible. So I think this should be decided at the local level, at state or county level. Once they have the information from the federal government, they can decide based on their situation.
Okay, so Dr. Levinson, can you give some examples of the different kinds of activities that hospitals report as a community benefit, considering that no one specific type of community benefit is used to determine a hospital's nonprofit status?
Yes, so as Director Lucas Judy described, there are 6 broad categories, examples of community benefits that hospitals can provide, and hospitals are also required to report specific expenses on specific types of community benefits through their Schedule H. So that includes, as we were discussing before, charity care, unreimbursed costs for Medicaid, unfunded medical research, unfunded medical training, and so forth. And then there are also opportunities in Schedule H to narratively describe other community benefits that hospitals might be providing.
All right, I appreciate that. I mean, recognizing that the IRS is responsible for enforcing a hospital's non-exempt status, I don't think anyone would be comfortable knowing that a random IRS agent is charged with determining if a hospital in my district is meeting the needs of a community. As I can tell you, the needs of North Texas do not reflect necessarily the needs of Congresswoman Fishbach or Congresswoman Malliotakis' district or anyone on this committee. So I look forward to continuing to further look into this issue to see how Congress can do a little bit more. And thank you very much for your testimonies today. I yield back.
Ms. Malliotakis.
Thank you, Mr. Chairman. My home state of New York is in a unique situation compared to many other districts in the rest of the country because practically all our hospitals are nonprofits due to regulations at the state level. In my district, in Staten Island in particular, I have 2 nonprofit hospital systems, and they do an amazing job. They work tirelessly to serve our community. I'm very proud to represent them. When we're talking about fair share value, meaning how hospitals contribute to their communities compared to the tax breaks they receive, I think there are some important aspects that may get overlooked. For example, more than 7 out of 10 of the patients my hospitals on Staten Island care for are either on Medicare or Medicaid or both. Public programs that have a much lower rate of reimbursement than commercial insurers, as you know. Medicaid reimbursement pays 60 cents on the dollar compared to private and commercial insurance, meaning that the hospital is eating 40 cents for every dollar. Ms. Lucas, Judy, my first question is for you. When the IRS is evaluating the community benefits of nonprofit hospitals in order to maintain their tax-exempt status, does the rate at which they treat patients on public health programs such as Medicaid factor into the equation?
So for the community health benefit section, what they're looking at is just some of the extent to which hospitals report that they are addressing those factors. But as I mentioned in the testimony, it's very open-ended, and so there really isn't necessarily an assessment of what. It's not clear what it is that the IRS would be assessing against, I guess is what I was trying to say.
There should be better metrics. There should certainly be better criteria to make this evaluation, and they should specifically take into account Medicaid, Medicare, that the hospital
Well, there are different parts. So under the ACA, there are certain requirements that hospitals have to meet, and there are other reporting requirements separate from these as well in terms of things getting at some of the uncompensated care. But some of the variability in what hospitals report, and one of the reasons why it's difficult to know the extent to which community benefit or what the full extent of community benefits is that hospitals are providing, is things like the extent to which the unreimbursed, uncompensated care for Medicare and Medicaid are included.
Okay. In addition to filling out the IRS tax forms to qualify for nonprofit status, my home state of New York goes a step further in requiring nonprofit hospitals to include budgets in their community service plans to demonstrate investments in evidence-based community health interventions. Dr. Bai, what are the advantages of Congress enacting changes to the IRS code that would require well-defined charity care minimum rates and/or detailed plans as to how nonprofit hospitals are providing community benefit?
Thank you. I think there will be several unintended consequences if we set a bright line rule. Let's say 2% of revenue. I'm just making it up. That will discourage current good performers, if there are, right, to reduce their charity care. Number two, there are some financially vulnerable hospitals are already struggling, especially in rural areas. If we set a standard apply to every hospital, then these financially vulnerable hospitals will be more vulnerable. Number three, these hospitals will lose a signaling channel, right? If they want to show the community, we are doing something that right now they can show in their higher provision of charity care or community benefit. But and we have seen evidence from academic studies, once you start this bright line, and then the hospitals might converge to that level, then we lose the signaling effect.
Okay. And one other issue that I heard a lot from my hospitals, not just mine, but across New York City, is the influx of the undocumented immigrants receiving care. It's placing a tremendous strain on the hospitals. It's overcrowding our emergency rooms, and it's obviously coming at a burdensome cost to taxpayers. Hospitals now have to shift critical resources. And I'm concerned about how that may diminish care for my constituents. And Ms. Hatton, is this something that you've been hearing from hospitals, and how would that factor in to nonprofits' charity care requirements?
If I could go back to your very first question about Medicare and Medicaid underpayments, which are pervasive in New York and other places, those are counted on Schedule H, and there's a specific way that they're counted on Schedule H. So the hospitals do get credit for those underpayments, which again in New York are quite significant, and those show up right in the numbers and are very explicit on the form. So they're definitely getting credit for that. With respect to patients who are patients without insurance, hospitals and who have no access to insurance, hospitals can do a couple of things. They can write it off as uncompensated care and then estimate the amount of uncompensated care that's attributable to patients who don't have insurance, which all these patients wouldn't have insurance. So there's a way to sort of account for the care and for the amount of care they're providing without any pay for that care right on Schedule H. And we encourage hospitals to do that so that you get a more accurate picture of how much care how much community benefit they're providing in free and unreimbursed care.
The chairman is giving me the eye. My time is up.
Thank you, Ms. Manotakis. Dr. Murphy.
Thank you, Mr. Chairman. Let me just start out first. Dr. Winstrup was not able to come, so I would like to ask unanimous consent to enter Dr. Winstrup's statement into the record, as he was unable to be here today, but as a physician colleague has valuable insights into this topic.
So ordered. And thank you for joining us on the subcommittee.
Yeah, thank you. Thank you guys for coming. Appreciate y'all bringing your expertise. Just as a point of reference, I've been a physician for over 30 years, was chief of staff of a level 1 trauma center, close to 1,000 beds. We had a 12 hospital system, close to $2 billion budget. So I know some of the language. We are a non-for-profit entity. I know some of the challenges over the last 2 years have been extraordinary, things hospitals have never faced before, travel nurses especially. Who would have foretold this and the exponential rise in the cost for travel nurses? I want people to earn as highest wage as possible, but it got to be the point where hospitals were actually closing beds because they could not afford the care of nurses. And I'm sorry, I took an oath as a physician, and I know nurses took an oath to care for patients. And I think, fortunately, the pendulum has swung back, and hopefully it will stay there. You want people to earn, but our first and primary goal, or first and primary oath, is to take care of patients, as are all people on the medical staff, including executives, C-suite people, and everything. I know medical supplies have grown. The inflation rate to Medicare is essentially non-existent comparatively. Absolutely abusive practices by insurance companies. I'm just going to be a little political here. There was a bipartisan law, bicameral law sent over to the president that was signed during the last Trump administration, and this administration has absolutely disregarded the intent of the law, given everything to insurance companies, and such to the effect that they send out letters to attack physician repayments and some of the other things. Absolutely wrong. So let's get back to the order of the day, and that's the tax-exempt status of a non-for-profit, which I think is a good thing. It allows institutions to actually be able to serve at-risk communities. I live in one, a very, very poor rural area in eastern North Carolina. But a couple things I'm going to ask different folks to give me some help with. Dr. Bai, I'm in receipt of some things I just don't quite understand, some 990 forms from one of the institutions in North Carolina I won't name, that shows some significant, and I mean billions of dollars, of offshore accounts from a non-for-profit institution. Can you tell me why would any non-for-profit do that? Why are they hiding money offshore? What's the purpose of that?
Well, we have seen evidence that nonprofit hospitals have been engaged in all sorts of activities that you would only expect in for-profit entities. For example, this offshore hiding, and then investment in private equity and venture capital, and then investment income, doing some quite risky investments and going after return. So this is only one of the example of this underlying trend that nonprofit hospitals have been behaving more and more profit-oriented and like the for-profit counterpart.
I mean, what's the motive for that? Is it to avoid taxes or something? Why are they doing this? Because it honestly just doesn't pass the smell test.
I think these activities, none of them is random. None of them is accidental. Everything's strategic for expanding market share, making more money, profit-driven. Yeah.
Okay, it just looks kind of funny when you got all of a sudden non-for-profits that are supposed to be charity institutions shifting money offshore. I will tell you, Ms. Matten or Haddon, I got a pet peeve, and that's CEO administrative compensation in this country, and especially in the chairman's remarks that the top 10 nonprofits average $7 million. I'm a physician, and I take care of patients. Nurses take care of patients, and I love my CEOs. One of my best friends is a CEO. But this is absurd, absolutely absurd, when we have charity care going on in this country where CEOs, executives are paid millions of dollars getting taxpayer money to get these, to run their hospitals. I'd love for you to comment on that. I have an extra 2 minutes.
First of all, let me thank you for your support for trying to get at the price gouging by staffing agencies. And I think you were talking about surprise billing, and thank you for your support there. We very much appreciate it. As you know, we were one of the original groups that went to court over surprise billing to vindicate that. In terms of CEO compensation, for tax-exempt executives, they typically go through a process to have the amount of their compensation reviewed by an independent committee that has comparability data. And again, everyone on the committee is independent to try to determine whether or not that compensation is reasonable and fair for that job. It's called the rebuttable.
Yeah, and I'll just tell you, I'm familiar with that.
Yeah.
But let me tell you, being on the other side of the coin, being up at 2 o'clock in the morning and saving the life of a gunshot victim and everything, I kind of get honestly ticked off about that, because I know boards do that and compensated care, but here we are. We're taking care of the patients. They're running hospitals. Why are they being paid more than the people who take care of the patients? I get it. It's important to run hospitals, big systems and everything, but it doesn't pass the smell test for patients when they hear about that. I've had patients come and bring their Medicare bill to me and apologize to me for the amount of money I get. And so when the cuts go through and we're trying to trim healthcare costs, guess who gets cut? The people who deliver the care. And so I think this needs to be a reckoning with boardrooms across the country, especially in nonprofits, charity care, that we need to re-examine CEO pay, because it's just not right. I believe in people earning as much as they can, but when physicians, the people who are delivering the care, when they've had a 20% cut in their average care in the last 20 years, but CEO pay keeps rising, it's absolutely absurd. So, I know you're not controlling it, but it's something that's really important to patients. And at the end of the day, that's what we're talking about.
Yeah, we understand, and just wanted you to understand that the process of setting that is a fair and independent process. And,
I get it.
And you can certainly argue with the results, but all the nonprofit CEOs use that to try to come up with a compensation that's fair.
I get it. I get it. But I'm sorry, I just don't get that they should be earning more than the people who deliver the care.
I understand.
So, all right. Thank you, Mr. Chairman. I'll yield back.
Thank you, Dr. Murphy. Mr. Hearn.
Thank you, Mr. Chairman. Thank the witnesses for being here for a couple hours now talking about this issue. I'm not a doctor. I certainly don't play one on TV, but I'm a business person, and somebody's concerned about where the cost of our healthcare industry is going. And, as we know, and I'm going to state some obvious here, hospitals play a very important role in delivering care to Americans in our rural areas, of which I grew up in. They're usually the largest employer in the first line of defense for miles when an accident happens, but the role hospitals play in urban areas is evolving. And I live in Tulsa, and we have really great hospitals there doing a lot of great work. In the 1960s, hospitals popped up all over the country as the only site of care. And more than 60 years later, there are several different types of hospitals that are not the only option for care. There are family physician offices, ambulatory surgical centers, urgent care centers, rehab centers, nursing homes, and the list goes on and on and on. The diverse options patients have speaks to the American entrepreneurial spirit and the freedom to choose. And as our healthcare system evolves, Congress must examine each sector of the industry to root out bad actors. And what we're seeing in these, and Dr. Bayou did a great job, I read your article, your research on that. We see the benefit from nonprofit tax status while delivering less charity care than their profit competitors. Abuse federal programs like the 340B to prop up their bottom lines instead of helping the members that they are supposed to be serving. Buy off-campus physician offices and immediately increase the prices by 200%. This is totally unacceptable. As a member of Congress, we must ensure the people that we represent are not taken advantage of and that the taxpayer money is well spent. Again, I want to reiterate my interest in rooting out the bad actors doing this, and there are many hospitals throughout the country earning their community benefit. I am fortunate, as I mentioned, to be in Tulsa, and we have several world-class hospitals that innovate and cut costs to compete with their competitors down the street. They invest in the community and make tough decisions while closing down units to keep their businesses running. Many hospitals across the country similarly contribute to their communities. For example, there are over 250 physician-owned hospitals which collectively paid more than $1.2 billion in taxes in 2021, and over 1,000 investor-owned hospitals similarly paid billions in taxes and provided 65% more charity care than their exempt counterparts. However, I can't say the same for many bad actors nationwide, so I want to insert for the record, Mr. Chairman, a report from the Progressive Loan Institute. Mr. Chairman, if I could enter this for the record, thank you, that outlines how out of this 1,773 tax-exempt hospitals evaluated, 77% spent less on charity care and community investment than the estimated value of their tax breaks. As a business owner, I'm a firm believer in getting the government out of the way, but if the federal government is providing hospitals $27.6 billion in tax relief, We must make sure they are accurately reporting their value and earning it. And the nonpartisan GAO concluded that under current law, there are no qualitative requirements for community benefits or charity care. Dr. Bayh, thank you for your testimony today. I appreciate how you describe your community benefit as a social contract between hospitals and their communities. As you know, the federal program provides many incentives to hospitals, such as the 340B program, paying more for services than in physician offices and nonprofit hospital tax exemptions. I especially like, as my colleague to my immediate left stated, in the 990, I like your additional requirements suggested for reporting these so we don't have to go dig through a lot of things. But to what extent are these incentives making it hard for small business healthcare facilities to survive or enter the marketplace?
Yes, actually, the current regulations are the major reason we're seeing more and more mergers and acquisitions and the small players leaving the market. And then the result is higher and higher price for privately paid patients. Like 340B program you mentioned, and the tax exemption status. And we have a banning from the ACA, banning on physician-owned hospitals. And the state level, we have a lot of certificate of needs law. And then we have the set non-neutral payments. We pay hospital more than physicians. These are, in my opinion, policy failures. Many people would say, oh, the high price is because market failure. No, the Congress and administration has made it very hard for small ones to compete and make the life of big ones easy. So these are fundamental policy failures. That's why we're seeing higher and higher price and less competition.
So if I may ask you in the last 12 seconds here, because I always like to ask our witnesses this, because you come here and you testify and you really walk out of here and you're saying, nobody asked me what we think we should do differently. So I'm going to ask you that. How do you think Congress can improve reporting to get a better picture of the community benefit? So I'm going to give you a chance to talk about your changes to the 990 as an example.
Very simple. Add several lines. Let hospitals self-report their estimated property tax exemption, sales tax exemption, and then charity contributions they received, and then the cost of savings, lower cost of borrowing because they can issue tax-free bonds. And also 340B profit. All these things can be easily estimated, no administrative burden whatsoever, but that will give taxpayers, stakeholders, policymakers huge transparency for them to make decisions.
And if I may, in your research, today's technology, that should make that relatively easy. I mean, I could see 20 years ago that might be a little bit difficult, but today that should be just adding and programming a line on the 990 software, right?
Yes, thank you, Mr. Hunt. And also, we do not want them to report estimate the federal income tax or state income tax because, accounting income is different from tax income, but all the other things can be easily reported, and they are really the meat.
Thank you so much, Mr. Chairman. I yield back.
Thank you, Mr. Hearn. I can't thank all of you enough for spending time with us. There's still dozens of questions. I was showing an article from an Arizona CEO of a nonprofit system that was paid $25.5 million in 1 year. You get questions when things like that happen. There is a number of hospitals, systems, now it may be because they're producing insurance products or other things, that I have one that has $1 billion in the Caribbean. Would help us to be able to have enough sunlight so we understand when we get questions on how we explain these things. So first, thank you for being here. I must tell you the intellectual level of the conversation was one of the best hearings we've had, particularly so far this year. And I now need to please be advised that members have 2 weeks to submit written questions, and do expect some questions from us, and answered later in writing. Those questions and your answers will be made part of the record of this hearing. And with that, the subcommittee is adjourned.